Well, Lorris, it's so great to have you back. Welcome back
Thank
to the
you.
University of Utah.
Always fun to return home.
Well, you know, I often tell people that you did all the hard work. You got the letters of complaint from patients, and you had people sort of complaining about their experience in the hospital, and now I get all these wonderful glowing letters, and you did all the hard work. So maybe you can start us off by just telling us what got us started in the whole journey towards developing that exceptional patient experience.
Perhaps the real proximate stimuli for taking this on were some experiences my wife had within the healthcare system here in a number of different clinics, and kind of in rapid succession. We started talking in the administrative level about patient satisfaction surveys where our scores were awful. 18th percentile overall for the hospital, and worse in many areas. Great in a few areas.
18th from the bottom.
Yeah, 18th from the bottom, yeah. And that just wasn't proud. So I started asking for patient letters that would come in. And up to that point in time, even if they'd been addressed to me, they got sent to the hospital CEO.
Oh, okay.
And so I hadn't been seeing them. Then I started reading them, and it clearly reflected experiences that we weren't proud to be providing to our patients. So, you know, I got kind of frustrated. I was also at a point in time, I should say, this was about 9 years into my time here as the senior vice president, where I wanted to have make one last significant mark on the organization before I decided to move out. And this just seemed so critical to where we needed to go to be successful. But it was interesting, as soon as we started talking about it, I mean, we hadn't even sent out directives to anybody about what they should do, but hospital units started doing stuff.
Just resonated
and our scores started going up,
yeah,
you know, just because rumors got out that the administration was talking about it.
Right. Well, most of us have been patients at some point, right? So we had some experience probably firsthand about where there could be improvements, right?
That's right.
Yeah,
exactly.
well, you know, one of the things that really struck me when I was interviewing here was just how fast the change had happened. Just even at the time that 3 years ago when I was looking at this position, it really took off very quickly. And for something like patient satisfaction, where you know everybody from the receptionist to the patient transporter to the nurses and physicians, of course, all contribute to that. And I just wonder, what, in looking back, what do you think are some of the, what would you say were some of the critical components of the strategy, or maybe just whatever happened that led to that rapid change?
You know, to me at the time, it felt like we'd taken a cork out of the bottle, that there was pressure in the bottle of a lot of people wanting to do the right thing, but not knowing that they had permission to do it. I'd never had any question that we weren't providing anything but the best care here.
Right.
And I think our patients came in expecting that we were providing only the highest level of care. But what they defined as a good outcome had more to do with their relationships and how they felt about the interaction and what the experience of coming to the hospital and trying to find a parking place and, you know, the whole gestalt of things. To them, that's what defined the experience. And there's a lot of that people other than the physicians could do, so that by the time the patient got into the clinic room, they were in a little more positive state of mind than maybe they used to be.
Right.
And that would then make it easier for the physician to sort of develop a relationship. I think the idea that being nice to patients is going to slow down the work that you do is not accurate.
You know, you talk about having the courage to change culture, to change everything in healthcare that we need to change. And, you know, at the University of Utah, we've been talking a lot about algorithms and algorithms for innovation. And I wonder if, as you reflect back on the experience of this major change that the organization undertook, whether you can identify or pull out some pieces that could be thought of as an algorithm that other institutions couldn't adopt. I mean, whether this is just simply it worked in Utah and it can work in Utah, or whether there's some lessons that can be really generalizable to other places trying to make the same change.
Yeah. I think it was key that while at the leadership level we said we're going to do this, this is going to be very, very important to us, we're going to start tracking numbers, we're going to start setting institution-wide goals, but we're not going to tell you how to do it. You figure
Right.
out at your clinic level, at your hospital unit level, what are maybe the one or two big patient dissatisfiers and work on them.
Right.
And then once you've taken care of those problems, find another one.
Right.
We started paying attention to hiring people for their values rather than just simply their skills or background. And over time that kind of changed the type of people that we had on board, and we began to move out those that weren't willing to do this, weren't willing to change. I think the real breakthroughs for us came when we started taking that transparency to the physicians. Really was a directive to the department chairs, start sharing your survey data with your faculty. And of course, the first thing the faculty would do is, as physicians always do, is to question the data. It's an
My patients are sicker, my patients are more complicated.
And then Tom Miller, the chief medical officer, at the end of the day said, look, we're all comparing you with the same ruler. And even if it's off by a little bit, for some of you, you're way down at the bottom. And you got to ask yourselves, why am I there?
Another benefit I think of the transparency that I hadn't really anticipated is in terms of preparing the next generation. So, as these trainees come through, when they're going on to a service, they go on and they actually look up their attendings and see what patients say about them, And so it kind of becomes a part of, well, of course that's how it is, I would Google my toaster oven when I want to buy it, and I'm going to Google my doctor or my faculty member, and of course when I come into the world, I'm sure people will be Googling me. And I think it's a kind of an interesting shift in mindset for the next generation because it becomes a given, that transparency becomes a given.
Who would have guessed?
Right? It's interesting.
So there are now a few more institutions doing it. Maybe we'll get to a day sometime when prospective medical students are going online and looking at the
I wouldn't be surprised.
satisfaction scores.
Yeah, exactly. Which would be fair enough, right? Fair enough. And
Exactly.
and I think what we're hoping to do now is to take those same lessons learned and apply it in a broader range of how we think about value in healthcare. So around quality, other measurements of quality, in addition to the patient experience, and even potentially down the line costs, which is going to be really interesting.
Well, it's pretty clear, I think, from our experience, our joint experience, shared experience, that the myths that doing the right thing for your patients is going to be bad for business is not true. As you know, at the same time that our patient satisfaction scores are improving, we jumped up in the United Health System Consortium rankings to #1, and have stayed in the top 10 for the last 5 years.
Yes.
And that is really a measure of the quality of the services that we're providing. And then you've been able to show that we're bending the cost curve down faster than other institutions are, and so the facts are that the costs are going down at a time when the patients are happier, and the staff are happier. The staff employee surveys are showing much better results.
You were so successful for over a decade, and curious if you have any parting words of advice for somebody who's trying to do some more change.
Part of what made the exceptional patient experience successful was that it came at a time when we'd done other things over a decade to prepare the organization to work in that sort of a collaborative relationship. You don't have time anymore to spend a decade preparing an organization for a change. You need to find ways to do it more quickly.
Well, I certainly think we're so lucky that we're building on the foundation that you set for us here at the University of Utah. So thank you very much, Lorris.
Thank you.